here. He's been an ardent supporter of broadband deployment. And if you know anything about Governor Quinn, you know that he's very passionate about the ideal that government really must serve everyone regardless of where they are and their level of resources. And he frequently uses the model, everybody in and nobody out. And that phrase certainly applies to the recent progress on broadband deployment generally, but telemedicine specifically. Governor Quinn, as I said, has been an ardent supporter of efforts in Illinois to greatly expand broadband service to rural and underserved areas, and because of its tremendous potential to create and expand jobs and to spur innovation and really transform healthcare. It tracks very well with our overall healthcare transformation efforts in the state of Illinois. The innovation and the expanded access to high-quality healthcare that broadband-powered telemedicine can deliver really does align perfectly with that ideal of everybody in and nobody out, so that the best quality healthcare can be delivered regardless of where you are as a patient. And so for that reason, I have no doubt that Broadband Illinois and broadband deployment efforts all over the Midwest will continue to enjoy the strong support of Governor Quinn's office. And again, I really thank you for the opportunity to say a few words on his behalf.
So continuing on our program, we already had a chance to hear from Governor Mike Beebe in the introductory remarks. So we're going to go ahead and move to our panel discussion on the broadband carrier's impact on telemedicine. I'll be moderating that panel, and I'd like to at this time invite Michael Morey of Bluebird Networks, Ed Simcox of AT&T.
Among other things, a huge transformation in our Medicaid program from a 90% fee-for-service system to a state mandate for moving at least 50% of those enrolled in Medicaid to some form of care management by 2015. That's a huge sea change for the Medicaid program. And accompanying quality improvement, again, getting a better quality care for what we are paying for. And really a big transition from institutional to community-based care. We do have a state law that created the statewide HIE network, the ILD. I'll talk about that in a second. And of course, as has been already mentioned, the high-tech provisions within the federal stimulus law were a huge driver of health information exchange for our state and others as well. The electronic health records, incentives for physicians and hospitals to adopt and then become meaningful users of certified electronic health records. And certainly we were the recipient of a good deal of HIE infrastructure funding, and of course the broadband funding really is the very baseline of infrastructure you need to make all of this work. And then followed very quickly by, of course, the Affordable Care Act implementation with all of its emphasis on accountable care, bundled payments, value over volume. All of these things were key drivers in our implementation. We are constantly reminded, however, that despite this recognition, this progress, that for many people, electronic health information exchange still means this. It still means picking up the telephone or sending a fax. And so in designing a statewide health information exchange infrastructure, we really had to think about how do we bring everyone up to a minimum level of connectivity so that we can drive forward and really get that high level of care coordination and quality. So in terms of level setting, there's a lot of variability around what it means to have an electronic health record, medical record. People use those interchangeably. What is health IT? When within the context of the Illinois HIE initiative, an electronic health record is really that certified electronic health record technology. It's health-related information on an individual patient. It conforms to national standards that is really critical in driving the concept of interoperability of those records. And it has to be managed and consulted. It has to be able to be managed and consulted by multiple clinicians across multiple settings. Health information exchange is really the movement of those certified electronic health records across organizations, again, according to national standards. So the goals of the Illinois Health Information Exchange Initiative is really to address those key policy challenges, and you'll see there's nothing about technology here. This is a healthcare transformation effort. It's technology is the tool, it's not the goal. So the goal is to improve health and outcomes and to control the cost. So certainly we want to take advantage of the federal incentives available to the state and really to enhance public health and disease surveillance so that we can really reduce those health disparities. So it's pretty clear who benefits from these efforts. It's really all across the board. I, as a patient, benefit from having my information available for more coordinated care and better outcomes, and having those who are treating me have pertinent information available at the point of care. Certainly providers benefit from having the information they always wish they had at the point of care so they could render better treatment. And payers certainly benefit from the reduction in medical errors and duplicative and ultimately, sometimes unfortunately, ineffective treatment that we render just because we don't know what else is going on with that patient. Oh, I see my triangle didn't. You have to envision a pyramid here. And really, it's just an illustration of how the ILHI network is really just foundational infrastructure for the kind of information sharing that needs to go on to facilitate care coordination and really get to that triple aim of better care, better health, and contained cost. And it's much like telemedicine infrastructure in that way. And I think that tracks well with sort of the topic of this panel. So when we talk about the ILHI, what is that? It is the network that was created by the statute. It's the core services and the standards that are operated and governed by that authority that was created to be the long-term governance structure for the network. It is a hub for secure communications and message routing. It is not a clinical repository. It is a transport network. And finally, it is a means of electronic exchange with state health IT systems. We really are taking an enterprise approach to the ILHI network and making sure that we leverage it for connectivity with a fairly rich set of data maintained by the state. This just gives you an idea of the landscape of connectivity for the ILHI. You can see we have certainly individual sites that are nodes on the network. We have regional health information exchanges. We are already connected to Missouri Health Connect and are able to send secure messages. But this is really the long-term landscape and really how we're building incrementally toward this kind of connectivity across the system. So briefly, the services that are provided by the ILHI. Our first service that we built was called ILHI Direct. If you're familiar with the Direct protocol, it is encrypted, HIPAA-compliant email, essentially, secure messaging, point-to-point. We've also developed a number of different statewide directories or registries, if you will. Although this is not a clinical data repository, we do maintain these centralized data sources in order to facilitate the kind of transit of the record. So you have to know who patients are. When you do a patient query, you need a master patient index. You need to know where all the providers are. You need the provider directory. And then we also facilitate connectivity to our public health node for electronic lab reporting, biosurveillance, and the immunization registry. Another service we offer is the medical record aggregation. This is the query-based exchange that sometimes people just assume that's what health information exchange means. It is one of the services, and it is where you send out a query to the network, and the network returns all available patient records available via other data sources connected to the ILHI. We do, of course, have to maintain a significant privacy, security, and consent management process to make all of this work. And then we are also positioning the ILHI as a platform for service extensions. I know there was some talk about APIs earlier, but we're really very focused on building only that infrastructure that is most efficiently and effectively developed at a statewide level, and really facilitating it as a platform for more specialized services to be built on top of it. The philosophy is if you go with a very standards-based approach approach. It will allow for innovation on top of your platform and really allow, I think there's a lot of opportunity for entrepreneurs to build on top of that platform for the sort of specialized services that are necessary for accountable care and really specialized disease management. So in terms of thinking about how health information exchange intersects with telemedicine and really where are these synergies? HID's, the query-based access to patient information, that really can obviously support telehealth because the more information you have during an e-consult, if you will, the better potential for care you have. Secure clinical messaging, again, the direct secure messaging allows information to be transmitted really to any user on the network. So once that user is authenticated and has access to secure messaging, it's point-to-point communication, but it really beats the heck out of a fax machine or sending records with the patient. We found it to be a very useful tool. And I think another important point is that the innovative use cases between health information exchange and telemedicine, telehealth are really still in the early stages of development. Both of these transformational efforts, these transformational tools are still young, and there's a lot of potential for synergies and the alignment of those technologies and the clinical workflows associated with them to get us where we want to go in terms of that overall transformation. So some of the challenges, which we always like to see as opportunities in this work, have been alluded to here. This is a very rapidly evolving landscape, and it's tough for anyone to keep up with all of this. Then again, a rapidly evolving landscape, it presents opportunities if you're ready for them that you perhaps had not thought of, and if you're communicating and aligning with those who are also engaged in this work, you find that there are some interesting, certainly some interesting opportunities pop up. We have, however, noted that there's a significant demand and a low supply in a lot of places for technical resources, and that's just in the form of software developers, integrators, the actual people who are plugging in servers in individual sites of care, and a lot of them are deployed doing things like ICD-10. They're certainly working on telehealth, telemedicine. So it's finding the resources to do this all at the same time. Again, both HIE and telehealth are relatively early on the adoption curve, and so sometimes trying to get those who are developing integrated delivery networks and new systems of care coordination to see the big picture and really to see the long-term potential of these technologies is certainly a challenge, but also an opportunity. And then I think the area certainly in HIE and electronic health records, and I think this is true also of telemedicine, is really the opportunity for patient engagement. And this is really sort of the last frontier of this work that I think is going to make all the difference. There's such a tremendous opportunity to get patients engaged in their health, and not just their health care, but in their health generally through these technologies. And I think we have a lot of opportunities, particularly if we evaluate these technical innovations together to really transform the way patients